Hello there, everybody. Nice to see you again. We're very excited to have an excellent guest with us today, Dr. Dan Kubikian. Dan is in the great state of New Jersey at the moment, where he practices periodontics. Going to talk a little bit more about Dan and what he does. But first, I want to tell you, I had the opportunity, this is what led to inviting Dan to be a guest. I had an opportunity to hear Dan speak at an event in Boston sometime last year. I think it was last year. And I was extremely impressed, not only with his ability to get across some fairly sophisticated clinical procedures that he was talking about, but I could sense that he really had a grasp of how you make these systems work in the practice. And I don't necessarily, I mean, how you put systems into practice to make them work. And as a practice manager for over 35 years, doing practice management, this is a skill that many professionals freely admit that they can improve. So I was impressed with Dan, and I thought, well, he'll be a terrific guest. And sure enough, we had a preliminary conversation, and it proved to be extremely interesting. As far as Dan's some basics, he grew up in Long Island. He's a local homie of mine. We grew up on near each other on Long Island. He got his DMD at the University of Pennsylvania. Did his 4-year perio post-grad program there. Earned the Chairman's Award when he graduated from U of P. He's board certified as a diplomate of the American Board of Periodontology. He's an assistant clinical professor in the Department of Perio at U of P. He is a featured lecturer in implant dentistry at U of P and at the Albert Einstein Medical Center. He has some street cred. And so, Dan, we're delighted to have you here. Welcome.
Hi, thank you for having me.
Yeah, of course. You know, I'd like to. I am particularly interested in not just the clinical side of things that you do, but which are very cutting edge. And I know that is what you lecture about. But I think there's a side here, and we discussed this a little bit preliminarily when we talked about how you make these work in your practice. I want our listeners to be able to get an understanding of more of this, and perhaps I could just sort of throw you a general question and just how did you first? Let's start at the beginning. You majored in pharmacy, and that led into dentistry. And tell us a little bit about that journey and how you did that.
Well, it's not that exciting. I didn't know what I wanted to do in going into college. And my father, who's an immigrant, and I'm a first-generation American, said, well, do something where you can at least graduate with a profession. So I went to pharmacy school, which was nice because it had the same overlapping credentials as medical and dental school the first couple of years. And then I decided I didn't want to be a pharmacist.
I get it. Okay, good. Fair enough. When you are asked to speak, Dan, I won't. Asking why is a little bit too broad. What are the things that? What are the areas of expertise that the people to whom you lecture are most interested in, and what do you find they really would like to hear about?
Well, so I don't think anybody really wants to hear from me in general, but I'll tell you what I think that I
Very
add as
humble
value
for people.
So as a as a private practicing referral-based periodontist, there aren't too many of us left, it seems. And what I rely on is I need the trust of the patient, the referring doctor, and the staff to sort of make things work. And I think that that's pretty similar with everyone who practices, independent of whether or not they're referral based or not. And then what I found is that, like anything else, if you start doing the same thing over and over, you become habitual, a little bit more proficient, a little bit more confident, and more competent. So whether you're a restorative dentist or a specialist, I feel those traits apply for us all. And the challenge is that when we are in dental school, we're being thrown with so many procedures and so many things to focus on. And so what, to answer your question, what I feel comfortable speaking about is things that I do every day, because I can represent it knowing what I do well and what I don't do well. And these things happen to be based, at least for me as a referral-based practice, on making sure that I know how to speak to patients in such a way that they're encouraged by their diagnosis. And I feel like what most patients need to hear is that everything's going to be okay, and this is not that exciting, and we're gonna do plan 1, 2, and 3, but can we just commit to step 1? Because oftentimes nobody wants a 10-step program. It's the first step that's the hardest to commit to. And if you have a low-hanging fruit with the first step for the patient, that increases the odds that they're going to do a second step, and so on. And with a referral-based practice, I have to know where my bread is buttered, and that's typically with the restorative doctors. And it's in my best interest to have restorative doctors who are trying to advance in continuing education, because the more educated patient that's referred, the more efficient and likely they are to know what their options are and to actually seek treatment. So what I feel comfortable representing when I'm speaking to doctors is something having to do with the all-on-4 surgery and replacement and restoration, because when I was at school, I was lucky enough to be in the perio pros program as well. And obviously I would not be able to practice pros in real life because nobody would refer to me, but it does come handy when it is outlined with the all-on-4 process. And the other thing that seems to be very helpful is educating the doctors with a study club. And so our study club has grown now over the last 16 or 17 years. And I think that it's important for me to be have my finger on the pulse of all the practices in my area, hoping that they give me a chance.
Excellent, excellent. How big is your study club, Dan? How
well,
many?
When we started, we had about 25, and over the years, I think 25 wound up being the low number. Some years were 30, 32. This year, it's just crazy because I decided that it would be a good idea to have a hygiene study club for hygienists.
Without a
And
doubt.
I thought that if we have the general dentists in our normal South Jersey Dental Study Club, it might be a good idea to provide them the ability to have 2 hygienists join for free. I had no idea the ripple effect that would have, because out of the 25 or 30 dentists, that's 60 hygienists. Hygienists talk to each other. Next thing you know, more doctors are being told to join the study club because their hygienist wants to be free in the hygiene study club. So it hasn't always been this high, but this year is the highest, which is 42. I think it's 42 members. Of the 42, we have some specialists. Perio, endo, I think we have 3 people. We don't have an oral surgeon. We have pedo, we have 2 orthodontists. So we have a pretty robust group. Of course, the majority are restorative doctors. And now our hygiene club we did in October, and I want to say we had right around 100 hygienists, which is really quite a bit. And our next meeting is in April.
That's very, very good. Very, very good. Yeah, we're very big believers in these hygiene study clubs for lots of reasons, not the least of which is they are very effective in stimulating patient flow and stimulating referrals, as you obviously know. What kind of question do you get? Do you find when you do the study clubs? Have you found that it indeed builds the relationship with the with these members of the study club, and it does result in greater patient flow or greater activity and communication and better outcomes. Talk about this a little bit.
Well, I think it goes in a wide range as well. I think that there are some doctors who come to the study club so that they can drink. I think others come because they can socialize. Others come because they want to learn. Some come because they want to do all three. And it's really hard to measure what you're getting out of it. It's almost like you're trying to create your lawn and you're throwing all these seeds out, hoping that when you're done, you have a proper looking lawn without trying to keep track of how many seeds worked and didn't work. So the idea of the study club, I think, is a pretty good idea because it gives doctors the opportunity to get out of the office and out of the house, have a nice meal, get CE credit, and learn. And some of them wind up referring and some of them don't. And then, you know, when it comes to having other seminars like the All on 4 digital restorative seminars I've been giving have surprisingly been a little bit of a bigger hit than we thought. Getting 30 doctors in a room at once is pretty challenging. So the first time we did that, I thought that it would slowly trickle away. Yesterday, I did my 7th seminar and we had 48 doctors attend, which is remarkable. I didn't think I knew so many doctors, but we've had 160 take the seminar and we've had about 15 take it twice. And then some of them wanted to bring their staff. So I think that that's one way to grow the practice as well. It seems like the idea is you have to have empathy for the person that you're either working on or working with or working together with. And I feel like that's a common theme, whether you're dealing with your employees, your staff, hygienists, providers, doctors, patients, referring doctors, spouse, children. I think it's nice to see things from the other side so that if you can represent their point of view, it helps you perhaps get what you want to get out of it as well.
No doubt. I'm glad you brought that up because I have a note here to ask you about that. I like that answer when I asked you a question when we first met, and you know, what is it that you think would be valuable to communicate to your colleagues, you know, about what you're doing. And, you know, you talked about the value, of course, and importance of competence and proficiency and so forth. But then you brought up this subject of empathy. You talked a lot about it, and I'm glad you brought it up. Let's drill on. I want to hear more about that. I mean, go ahead.
Well, I kind of feel like an example of this is if I have a new patient in the chair, looking at it from their point of view, they're outside of the office that they're used to being treated at. They have to fill out a new medical history form, new waiting room, new faces. And if it's periodontal related, oftentimes they have no symptoms or pain, so they don't know why they're there. So I have a very brief period of time to gain their trust, have them make decisions, and then execute the treatment, knowing that they don't know how much things are going to cost and how much is going to be covered under insurance. And I think that what I've developed over time is no different than what everybody else develops, which is you sort of develop a story that is based in fact, and then you can apply to the patient's situation. So as an example, when a patient is in the chair, I can say something to them like, you know, when you see your dentist, the dentist is trained to look in your mouth for 2 problems. The most common problem is a cavity. So if you ever get a cavity, the hope is that it's fixable with a filling because a filling is fast and cheap. Now, immediately, the way you're nodding your head is the way the patient is nodding their head. And that's important because the first agreement is the hardest one to get. And then as this conversation continues, the hope is that they continue agreeing with you because what they're doing is verifying in some ways that you're telling them things that happen to be true and they can verify it. Because later on, you're going to tell them things that they cannot verify as being true and they have to trust you. And if you have a pattern of trust built in your story and, you know, ethically, then you have a higher chance of them feeling comfortable believing you. So the other problem the dentist looks for other than cavities, and by the way, with cavities, you hope it's a filling because it's fast and cheap. Everything else is a fortune. So like root canals and crowns, I don't know, they're almost $3,500 or more where I am. And the
Yeah.
dentist will generally lean you towards saving the teeth because saving the tooth is faster and cheaper than replacing the tooth. So typically you want to save your teeth. Now, I can tell you, nobody argues with me on this. They're vehemently agreeing. And then I say to them, the other thing the dentist looks for is periodontal disease, which is when people have gum and bone loss around their teeth, but usually there's no symptoms or pain, so nobody really knows they have a problem. The good news is the treatment for periodontal disease is very fast and cheap, typically $200 or $300, and that's not per tooth, that's cleaning per side while the patient's numb. So what do you think I tell patients who have periodontal disease? I'm telling them, save your teeth. So the general bias is try to hold on to what you have. After looking for health, then the focus changes to function. Function means, does the patient have enough teeth to bite and chew? And you don't need all of your teeth. So out of the 32, most people have 28. Out of the 28, you need 24. Because basically what we're taught is to prioritize first molar occlusion. So I give them like this little background. Then, of course, I talk about tooth replacement options. But the idea is that I'm trying to level the educational playing field so that they can help make the decisions that they feel are in their best interest from a reliable source, giving them reliable information.
Very good. Excellent. Excellent. How much time would you say you spend in a consult on an average?
It's not that long. I would say that 20 to 30 minutes, I would say. Now, the appointment might be an hour.
Yes.
But by the time they come in and get situated and they get maybe whatever x-ray they need or a review of what they're in for, I try to keep my time as efficient as possible within reason.
Yeah. Yeah. Good. Yeah. Makes sense. Makes sense. Well, consider the volume of work that comes out of your office. You can't be spending too much time in consultations.
Yeah, and it's challenging because you need new patients
Yes.
constantly. And so for what we're doing, and I'm very lucky, I have two wonderful associates, Dr. Allison Gilbert, who's been now 5 years, and Dr. Anna Kodra, who's been for 5 or 6 months. I mean, they're very proficient, they're honest, they're hardworking, they're kind, they're empathetic, all the qualities that I think are very important. And you have to do better today than you did yesterday.
Good. Well, having those kinds of associates is, you could call it a blessing.
Yeah, it is. They're great.
Good luck too, but it's yes, we know we've been through this many times. Understood. So Dan, let me ask you. You've been. You may not think this, but you appear to be an early adopter of new technology. The things that you're doing that I'm familiar with in your practice, the clinical systems and procedures are pretty. Are cutting edge. I mean, you are using cutting edge technology, and I think the people listening would like to hear a little bit about what you're doing. I'm not asking you to go into a clinical lecture necessarily, but in general, what are you doing, and how has it enhanced your clinical capability? I know from listening to you that it's helped strengthen your relationships with your referral base for some very, very obvious economic reasons. Makes all the sense in the world for them to refer to you because they make more money when they do, at least per unit of time. And I'd like to hear your thoughts about this and how you see it.
Well, I mean, I think we're all in a position where we have to decide or try to figure out what is and isn't a wise investment in time, money, people, employees, and so on. And so specifically when it comes to equipment, when I got fired in 2008, I was in severe debt. I just graduated, young kids, mortgage, cars that I owed a lot of money on, and then I had to call my parents and say, "Hey, can you purchase a 1,100 square foot condo for me because I have to take a $500,000 loan from Bank of America and open." And the reason I'm giving you this background is because taking on all this debt on top of more debt was not convenient. And what I was struggling with in 2009 was I felt that having a cone beam scan machine in the office would be a good idea, but they were 130,000. My
Yeah.
parents are retiring general dentists at the time. They still had film x-rays. So for me to be pitching that I want to buy a $130,000 machine for something that they don't even know what it does
Tough
was a
sell.
hard, yeah, it was a tough sell. So the idea was, I thought, maybe when the patient comes in interested in an implant, maybe instead of sending them out, which now I'm relying on a third party to have the greeter there, the scheduling of the cone beam scan, getting the CD and so on. I wonder if it wouldn't be more efficient if I had the machine in. And while it didn't pay for itself initially, it did help get cases streamlined. And I think that that was an added value. And I think that when you make these decisions, they're not all always going to be right. But I think you have to try to make it slightly unemotionally so that you can sort of gauge what might work. And then as time went on, it was a matter of saying, I think we need more chairs. We could work with 2 or 3 chairs, but I think we could be more efficient with 4 or 5. And then it's the investment of trying to build out more. And it's a risk reward because you have to maintain your patient base. Like for me, there are 3 variables which are very important. The first one is making sure I have a patient base. And because I'm fixing people, the phone has to constantly ring. The second is making sure that we have proper providers and staff. So labor means providers generally mean trying to have doctors and hygienists, and staff means having administrators and clinical staff.
Yes.
And then finally, it's a matter of having a facility that can do it. So for instance, when we moved from our 2 to 3rd op, it was maxed out already in that small space. So then several years later, it was an idea of saying maybe I should move, which was kind of a big deal. So then the moving was done to go from what amounted to be 6 to now 9 operatories. And the way that technology helps and the investment in technology helps seems to be trying to provide the patient, in this case, I gave the example of the cone beam scan, but also the dentist, the ability to get the cases done in a more efficient manner. So that's a clear efficiency with time. It also became an efficiency with money because the cone beam scan happened to be less expensive than the CT scans they were getting at the imaging centers anyway. The way it parlays into today's world currently for me is that I invested money in getting photogrammetry. I also invested money in getting intraoral scanners, which as a periodontist wouldn't seem to match. But the advantage was that I'm now creating a situation where the patient, the dentist, and the laboratory are more likely to have predictable results with more streamlined process. And that helps everyone, particularly the patient.
Yes, without a doubt. Well, it saves a tremendous amount of time for the referring doctor as well.
For sure. There's a ripple effect. If you can save the patient time, save the patient money, save the doctor time, and allow them to maintain their profit, and also help the lab, those types of systems tend to work. And sometimes there's feedback from patients and from staff on systems that are good or are not good. As an example, we implemented something like text messaging about 8 or 9 years ago when not everybody was using a phone or even going online all the time.
Yes.
And in the beginning, it didn't seem to work very well because some people didn't have cell phones for real. But today, the same technology happens to be very useful in confirming patients. So
Yes.
I think what happens is you have to have the courage and the flexibility to make decisions with the information you have in that moment, with the understanding that you're supposed to look back and rethink and see whether or not that decision needs to be either modified or scrapped or enhanced.
Yes, very good. Very, very good. Um, Dan, I'm curious. You think I don't mean this as a demeaning remark to your colleagues at all, but you think in a very global, so in terms of the practice way. You think in terms of organization and workflow, and in a very organized manner, which is it's fairly unique. I'm not just stroking you here. It's actually, and I'm sure it's helped you tremendously in your practice. And this is why many practices hire us, of course. So I'm wondering, how did you develop this kind of more management, and you may not even view it this way, management oriented attitude about the operation of your practice? I mean, it's operations. I'm very interested in your operations. I've got to come there and watch someday.
Yeah. I think that I think it's helpful if you put yourself in the position of the patient, because I've been a patient, and when I walk into a room, the waiting room, I would like to be greeted. I would like eye contact. So
Yes.
the staff at my office is pretty good at that. And if they are meeting two new patients for the first time, and one of them is 30 and one of them is 80, they're able to greet that patient by name the first time they see them. And they're the first face, the first voice. Even the people who answer the phone to take on our call center with the new patients, I don't want that outsourced. I want us doing it. And, you know, they joke and they laugh and they have fun, because I don't want the people who work with me to be scared. I want them to have confidence, and I want them to feel comfortable making mistakes, comfortable admitting mistakes, fixing issues. And I think that if you have a staff, like, you know, I've had staffing issues. One of the main lessons I learned is you may not want a lean and tight staff, because if someone goes haywire, you may lose 20% of your staff with one person leaving. That's or right. Two people leaving, you lose 40%. That's so right. We have 20 something people now. And in order to have 20 something employees, you know, we've gone through probably 120 employees to get 20 good ones. And they build a culture and a system that is self-monitoring. The same can be true with negativity. If you have the wrong employee, they tend to harbor the wrong employees and the bad attitudes. So as a patient, when I walk into a medical doctor's office, I'm looking to see, are they happy to see me? Am I just another number? And when I sit down into the room, is the chair dirty in the waiting room? Are the sills clean? Do I hear people complaining in the back about their job? So, I mean, think about if you go to a nice hotel, your expectation is that they're welcoming you home. So in our office, the way we have it is, it doesn't seem like a dental office. There's no hint anywhere that it's a dental office. Even when you enter the operatory itself has a standalone chair. There is a light on the ceiling, but there's nothing attached to the chair. Now, for me, I like that. I've gone to these shows where I see the companies selling dental chairs, and the dental chairs look the same way they did 30 years ago, with the addition of an LED light or an LED spotlight. And I think that they're missing the boat, because when you walk into a dentist office, you're oftentimes scared. And can you imagine having the burrs and the hand pieces laying right next to the chair? I mean, why don't we just put the needle on the patient's lap as well? So to me, I think dentistry needs to be rethought. I think that when you walk into a room, at least for me, it works, where all they see is a chair, and they sit in the chair, and you would know what type of office you're in. Because, and I like to do this, I know there are disadvantages, but I like to work out of the 12 o'clock position. And because I do that, I'm able to completely encase the entirety of the 12 o'clock unit, and then unveil it once the patient's in the chair. And that's when it gets revealed. That's where the drills are, and the hand pieces, and the extraction forceps, and so on. And so I think that it's important to be able to create an atmosphere where people feel like they're not to be intimidated. And I feel like sometimes dentists who want to be doing a lot of surgery, meaning general dentists who want to do a lot of surgery, which they have every right to do, they try to make their operatories look like surgeries. I'm trying to do the opposite. I'm trying to make it so that people just walk right in, sit down, and they don't have any inkling on what's about to hit them.
I think that's brilliant, Dan. I actually think it's brilliant. Did you have are these things that you simply by observing the obvious, observing the obvious, and you talk about empathy? I completely understand, because everything you're saying really communicates what does the patient want to experience when they're walking in. Do they want to look at these instruments of mass destruction, or do they want to walk into an environment where they're quite comfortable and they're talking to somebody and there's nothing there that's going to, scare them to death? This empathy, I think that message really does come through when you talk. But I'm interested in, have you had mentors or individuals whom you felt were, okay, this guy's really got the right idea, and this was somebody that you learned from? Or are these just the lessons that you've learned and evolved over the years, and seeing what works with your patients and your staff?
Well, I think it's become contagious.
Mm.
So I thought that building the second office, every operatory should have a window so that the patient can look outside. Then a patient comes in and says, you know what? You ought to have bird feeders. So now every room has bird feeders, and every
That's
patient
great.
says, I love the bird feeders. And then
Wow.
our hygienist who became the office manager, Jody Crystal, says, I don't want this place to smell like a dental office. So then she went and she bought the Ritz-Carlton or the whatever hotel it is. You can change the scents, and it goes right into the HVAC unit. So patients walk in, and during the holidays, it smells like pine. And during the summer, it smells like refreshing beach. And I think that all of this stuff is not something somebody can necessarily think of in the moment, but I think that it just layers on top of each other. And a lot of patients really like it. Every window has a candle with one of those fake flames, but it looks like it's real. And patients want to know, where did you get the candle from?
Yeah.
Every room has a funny saying that we changed the board, like, don't blame the holidays, you were fat in August, something that's light and
That's great.
entertaining. So these types of things are not all designed at once. I've been doing it for 15 or 16 years. And then, a little bit at a time, it gets added on. And that's it. It's not really that genius or anything. It's just me being selfish for what I would want if I were the patient. And I want this, and I want this, and I want this. And so then I said, okay, well, I'm not the patient, so I have the ability to make the purchase and do it. And I think that this is the tricky part, because the advice that I'm giving, I have no benefit. I don't sell stock in a candle or in how you want to make a dental chair or how you want to make a 12 o'clock unit. I'm telling you things that happen to work for me with no vested interest from my angle. But this is the challenge in dental school and in corporate dentistry, which I'm finding, because everyone has an angle. So as an example, I think DSOs are great, but they're not all great. The same way private practitioners are great, but they're not all great. And so I think it's important, and this is a little bit of a different philosophical conversation, but I think that the greatest part about being a dentist is having the ability to own your own business.
Mm.
This is what, like, America is built on. So can you
Amen.
imagine going through all this school and trying to figure all this stuff out, and in the end, you're working for the man who's telling you you can't use this material and you have to do it a little bit faster
Yeah.
because you're too slow,
Yeah.
and you don't know the patient, but you just need to walk in and do the surgery, and you become labor. And I think that the beautiful part about owning your own practice is you become a better human being by realizing that you need to get along with everybody. And
Mm.
it's very humbling trying to work and manage people, because I know that we haven't been trained for it. So a lot of times a dentist will say, oh, I want to work for this company because I don't want to have to worry about if the assistant calls out. Well,
Yes.
is that really true? Because
Yeah.
when your assistant calls out, what you're basically doing is you're saying, I can't solve my own problem. I'm going to rely on someone else to solve that problem.
Yes.
And there's no guarantee that they're better at it than you. So from my perspective, I can handle my own problems. I don't need somebody to take care of me. And I am the wrong person to talk to if you want to be an employee. As a matter of fact, when Dr. Gilbert started at my office as an associate, she almost thought that I didn't want her because I kept encouraging her to be open to opening her own practice. I think it's very healthy. And the government has a lot of incentives. Why do you think private equity is so into owning dental offices? Because there's a
Yeah.
lot of financial incentives from the government. So I can do it. I can put the candle in the window. I can put the bird feeder outside. I can make it my own.
Yeah.
And I love it.
Yes. 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 I could not agree with you more. I could not agree with you more. The idea, I mean, I always felt from the outside and with working with doctors for so many years is that one of the reasons that an individual became a doctor was because he or she they could be running their own business.
Yeah.
They could be running their own business. They could be, the growth. I won't get off into a tangent on this at all, but our driving principle for our company has always been that practices won't grow beyond the level of these skills that you're talking about, Dan. These people, these management, administrative. That I don't like the sound of that, but these people skills is what you're talking about. This empathy. But because clinically, most people are here, most doctors are there. But when it comes to administrative, they're down here. There's a huge disparity. But what I enjoy about in listening to you is that, and then we've said this, that when you raise this other set of skills, even somewhat commensurate with that clinical capability, it's enormous growth potential.
Yeah, I
And
agree.
you get a synergism there that is enormously powerful. I think
Yeah,
you understand
it's
that.
contagious. It is contagious. And the thing is, you don't stop learning dentistry, the actual procedures when you're done with dental school. You have continuing education. And I think that as a human being, you have to have continuing education. And
Yes,
so I would not be so hard on ourselves when we don't know how to run a business, because most
yes,
people don't. And
yes,
you have to have some patience. And
yes,
I mean, it's not that exciting. It's not like you're running like a Fortune 500 company. You have options, you have decisions to make, and you're going to make mistakes. So what? Everybody makes mistakes, and
sure.
you have to have some stick-to-itiveness to work through it.
Yeah,
I would encourage everyone to seriously consider um, working for themselves or in a practice that they own.
yes. So would I. So would I. All right, let me ask you this, and on this subject of, I know you'll probably discuss empathy, but 20 staff is a lot of staff, Dan. I know you have an office manager. I imagine she's pretty good at what she does, and she handles a lot of staff related issues. But anything that you'd care to say about how, and I understand also the churn and burn. You said probably 200 to get the 20. Nowadays, that's probably not an unrealistic ratio. They say it used to be they'd say you got to hire 3 before you get 1 keeper. I think it's more now, just based on a lot of cultural factors, which we don't need to get into. But I'd love to hear just anything that you'd care to say about how you have evolved this group that sounds like I imagine people still come and go, but that it sounds like it's a pretty stable group right now. And I know doctors are always dealing with this, ruminating on it, stressed by it, and everything else. And I'm interested in what you might have to say about that.
Well, I want people who want to make more money working for me, really. And I know that puts pressure, but I want them to do better and better every year.
Yeah,
And I
good.
don't want them sitting at a job that has no advancement potential. And
Mm.
even though those are nice words, they want to see it in their paycheck.
Yeah.
So, our office is open 5 days a week.
Okay.
All of the money we make on Monday and Tuesday and half of Wednesday goes to the federal and state government for taxes.
Yes.
Then we have the rest of Wednesday where we start paying for a lot of our supplies. Thursday, all of the money we make goes to the employees. Friday, all of the money we make goes to the doctors. That's our business. So
Hmm.
I want a raise too. I mean, we all want raises. So how do we get raises? Well,
Yeah.
we have to grow the pot of money. Otherwise, there's nothing to redistribute. And
Yes.
if we shrink the pot, then we have to make cuts if the pot is less. So
Hmm.
if you want to make more money, which I want people who want to make more money, the easiest way is to become as knowledgeable as possible. So you're as valuable as possible. And the more
Hmm.
valuable you are, the more likely the practice is to do well. And
Yeah.
that's the ripple effect.
Yeah.
And so I misspoke when I said we had 20 people. We have 25 people, but that includes me
Okay.
and the two other associates.
Okay.
And um, we do get turnover, but not too much anymore. And most of it is because what I can control in the back are the clinical personalities within reason.
Mm-hmm.
And I encourage everyone, I compliment them in front of patients routinely. If the x-ray they took is awful, I'll say to them, hey, this is a tough angle. You think you can re-angle it one more time? I'm really sorry to make you do this again, guys. And the patient says, oh, it's no problem. And the staff says, oh, yeah, no problem, Dr. Kubikian.
Yeah.
They're very intent on pleasing me. And
Yes.
I'm very intent on making them feel good about themselves.
That's
And that's a
very.
nice synergy.
Yes.
So that's what I do in the back. And then
Yes.
what I try to remind them in the back is how hard the front is working to be able to
Yes.
get people scheduled. And then I try to make my way to the front and see how they're doing. And, just make small talk with them so that they know I'm there and I'm
Yes.
keeping an eye on them in a kind way. And I try
Yes.
to compliment them and make fun of them and so
Yes.
on so that we have a nice synergy. And
Yes.
I think that if I was a jerk, they're going to emulate my jerkiness. And if I'm
Yes.
trying to be a nicer person, maybe that increases the chance they're a nicer person. And what
Yes.
I found is this is not always true, but I think when you work anywhere, and it doesn't have to be a dental office, but of course, that's what I'm referring to now.
Yes.
That's your second family where you may be spending more time with your second family than you do your first.
Without a doubt.
So, like any family, you have to limit the dysfunction. And I found that it's hard for people who were raised in real life in dysfunction to last long in our office because they don't seem to know how to behave and they emulate behaviors that they may have seen at other offices or perhaps growing up at home. Now, there are exceptions both ways to that, but I found that there's a major advantage to someone who is coming from a good situation at home, independent of their age, because they seem to fit in better in our office.
Hmm.
So it's like a second family. And,
Yeah.
I make mistakes and I want them to know that I know that I make mistakes so I can apologize. Um, you know, it's what I expect out of them.
It's very good. It's very good, Dan. And how do you screen, for lack of a better term, for those characteristics?
Well, I don't know. Sometimes it's like dating. The first date you go on, the person's going to show you the best of the best. and then you keep dating, and then you're like, oh boy, okay, there's warts here that we have to maybe consider to address, and so on.
Yeah.
And it's not really a black and white issue, right? It's like anything else. We're all trying to figure it out, and you hope you figure it out sooner rather than later.
Yes. Yes. Very good. Very good. Great. 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 It's great listening to you, Dan.
Likewise. Thank you
Yes.
for having me.
What a pleasure. What a pleasure having you. Where, where can people find you? Where can people find you who'd like to contact you for, I'm sure would be positive reasons. I know that you're doing a lot of lecturing. I know you do a lot of continuing ed. But how do people contact you?
Well, I should be better. I should be better at this. I should be able to rifle out these answers so fast. But I know that our practice is SJ Perio, SJ for South Jersey. So I think our handle on Instagram may be at SJ Perio. And I
Okay.
say it that way because there is another practice in South Jersey that reversed our name. So I may be referring you
Perio
to
of
my
South Jersey.
competition.
Perio of South Jersey? Did they go
So,
Perio of South Jersey?
we're South Jersey periodontics
Yeah.
and dental implants.
Okay.
And I think they're South Jersey dental implants and periodontics.
Okay.
So
Very good.
I hope I'm giving you the right address to our office. But yeah, sjperio.com is our website too.
Okay.
And
Good.
you know,
And you were in what city?
we're in Sewell, New Jersey, which is
Sewell, right.
in
Sewell.
southern New Jersey. Yeah.
Okay.
We're about 15 miles away from Philadelphia.
Ah, wow. That is south, isn't it? Okay, good.
Yeah.
Good. Wonderful. Dan, what a pleasure to have you. Thank you so much. It's just been a great experience getting to talk with you and getting to understand and know you and hear what you have to say. Appreciate you sharing your wisdom. Wish you the very best of luck, and hope we talk again soon.
Back at you, Allan. Appreciate you. Thanks.
Okay.